Assalamu alaikum. Welcome everyone on board. Um, as we have started to have a basic concept about the basic the the anesthesia care, which is we do daily and the basic principles. Okay, so we have done already some points about doing the preoperative risk assessment in the form of history examination, investigation, then chalking out risk factors, and how to anticipate them intraoperatively with reference to different surgeries or different disease. And then we had some words about how to deal with anesthesia complications. Then yesterday we did some points about multimodal anesthesia uh, and some more topic. So today, actually, I was just thinking that any surgery, whatever surgery we are doing, is in any specific position. Okay, maybe it is supine, maybe it is prone, maybe it is lateral, maybe it is lithotomy, Trendelenburg, reverse Trendelenburg, sitting position. Okay, so every position has got its problems. Okay, so yes. So, we should have a concept about what are the concerns related to positioning of the patient. So, I will just try to give you an idea that what things you need to consider whenever you are doing any positioning. Okay. So, first of all, whenever we place any patient in any position, we need to fix that position. Okay. So fix with in the form of straps. Okay. And if, for example, either the hands and joints will be tucked inside in any position, or they will be outside. So if they are tucked with the patient, then because the IV lines will be there. So it is better you fix the IV lines course, because once they wrap the patient, then it will be difficult for you to access the line and access the that area. So it is better once they are positioning it, it is better to fix it, and specifically your like pulse oximeter, your IV lines, you have arterial line or anything, even endotracheal tube. So you need to fix the patient as well as your lines, okay, your tubes. So this is something very important. Even I tell you something that, for example, Foley's. There are so many incidents in which Foley's is stretched and there is urethral injury, and that patient will have a miserable life forever, because it once urethral injury, unfortunately, they will be in trouble for a long time, because there will be urethral stricture or something. So make sure this is directly not related to you, but it is something very important. Okay. So in addition to your IV lines, arterial line, NG tube, whatever, it can be anything. It can be chest tube. It can be temperature probe. There are so many things which you are attaching with the patient. Temperature probe, rectal probe, whatever. Okay. So don't forget the word this fix. Okay. Can you mute your mic? Thank you. So then another important thing is that you need to, because one thing will be with reference to the lines and the patient, and then other things will be the all the joints. Okay, joints should be in optimal position. Like for example, now patient is anesthetized, for example, either in the even in with reference to lithotomy position. For example, the patient has osteoarthritis or patient has frozen joint, and now you should be knowing when you are doing the preoperative assessment, and you know that this surgery will be done in lithotomy position. You should be knowing whether you can do the lithotomy position, whether you can whatever, like what is the range of movement for the joints. This is very important. Okay, so you should be knowing about it, and you should know what, because if, for example, you try to do more than that, either you will have joint dislocation, or fracture or anything like that. So this is very, very important. This is true for, I've given you one example with reference to lithotomy position. It can be any position. It can be anything. Like for example, joints, with reference to joints in the spine, for example, neck. The patient had atlantoaxial subluxation, you don't know, or stiffness, and you try to make too much positioning during, out of the range. That's why I'm using the word range of movement. Whatever the allowable range of movement for that patient in that scenario, you should be knowing about it, and you should never, because if you do it, maybe you will have some neurological deficit postoperatively, even something very serious. Okay, so this is with reference to, now you can put it in all joints, whether it is knee joint or ankle or hip or shoulder or spine or whatever. So this is very important. Okay, then pressure points, because this any whatever position you do, you should be having special care about the pressure points. Okay, and in this one, fixation monitoring, I will just add it, like ECG or pulse oximeter or like anything. So this thing, pressure points may be secured with there are specific jellies. Okay, which are uh, presented in placed in that places. And another thing with reference to important thing is either direct compression of the nerves. Okay, even soft tissue, like for example, breast tissue, you need to take care of that pressure point. Genitalia, like testes. Okay, then after that, with reference to brachial plexus, so axilla, brachial plexus, axilla. So like you should any whatever position, because I'm not going in details of any specific position, but usually I'm just telling you the like any position. These are the basic principles. These are the basic principles in any position. Okay. Anyone wants to add to this concept? Anyone, anything which I have missed? Like we talked about fixation in that specific position. Okay, it may be done with the belts, with the wrapping, with, and then fixation, anything which is attached to the patient, the circuit, the tubes, the lines, foley's, anything like that. Then we have to take care of the pressure points. You have to take care of the pressure, like genitalia, breast, brachial plexus. Okay, so this will be the basic principle. Anything which I have missed? Anyone wants to add to this point? Okay. So the next thing will be, one point will be that when you produce that position, there will be some effects, and then when you reverse that position, it may be true in it may not be true in some position. Just a second. What is the message? Very good. Thanks for adding. I missed it. Eyes. Very good. We will actually, whatever things we have missed, we will just try to cover when we go to the specific positions. So eye, very important, especially not only with reference to, actually people are afraid only with reference to prone position, but actually even if you have in supine position, even then you have not only to cover, you have to avoid pressure. Okay. And another thing which usually people do is to put lubricant. And actually, sometime lubricant itself, because these are not pure lubricants, they have some antibiotic. They have, you don't see what is the constituent. So maybe you end up having allergy or any hypersensitivity to, yes, neck. I have discussed that. So maybe like in eyes, you not only have to cover it, you have to avoid extra pressure. Lubricants, as I told you, there you should not put lubricant until unless it is required. Some people just make it a routine to put lubricant. So this is like a message that you don't need. Then another thing is that sometimes some people cover it with the gauze piece. Okay, it's It will be depending on what sort of surgery it is. Sometimes you have to protect, if for example, if any surgery which is near the eye, like for example ENT surgery in which eye is exposed in front of so and in that case you will be taking more care. Otherwise maybe only covering with the gauze this like offsite or tape may be enough. When you cover it, try not to have too much pressure. And another thing, well, because you know in some patients it will be important that to try to take care of the eyelashes, because eyelashes, when you pull it out, it can be a problem. Eyelashes or eyebrows, you have to take care about it. Okay, so this thing. So whenever you do any position, you produce that position and you reverse that position. So you have to take care when you produce that position, there will be some changes and there will be some reverse changes. So this is the second step you should be concentrating whenever you are doing any position. Okay. So usually whatever effect will be, one of the part we have already covered, that whenever we generate any position, you should be taking care of everything, anything attached to the patient. And then, of course, the systems you can chalk out one by one: CNS, CVS, respiration. Usually, these three systems are usually in have the effects in whatever way. Okay, and then in there may be changes in pressure in body cavities. Again, last item. What did you say? Which item you are telling? CVS, CNS, and respiration. Can you speak out, please?
Yes, produce and they reverse.
Yes, reverse, produce and reverse. When you reverse that position, okay? When you produce
What do
that
you
position,
what do you mean?
like like you, for example, you do lithotomy position, that is to produce that position, and then you reverse it, okay? You make Trendelenburg, and then you make it straight again. You make reverse Trendelenburg, and then you make it straight. So you make the prone position, and then you reverse. So there will be concerns in every position to there will be changes which occur when you produce that position, and there will be reversing of these things. Okay, I hope I answered your question. Is it okay?
Yes, okay, thank you.
Okay, so um, usually the effects will be in CVS respiration, as I told you. And for example, in CVS, whatever happened, there will be either effect in venous return, and then venous return will affect the cardiac out. Simple, very simple. Okay. So you whatever effect it is happening, usually, for example, you do a lithotomy position, there will be auto transfusion of the blood in the system. Okay. So venous return is increased for a while. And maybe if a patient has limited cardiac reserve, like patient is not used to receiving extra 200 mils of blood, it can create a problem. Okay. Similarly, if you now you reverse it, now, what will happen? It is just like you lose 300 or 400 mils of blood. I'm just giving you example. Like you reverse it because now the body is tuned to it. When you reverse it, actually what has happened? What has happened is like it is creating a situation in which body has suddenly lose 300 to 400 ml of blood. It will be readjusted within few minutes or within few seconds, okay, according to the patient. But maybe again, a patient who have problem in autonomic nervous system will be at risk. Okay, extremes of age, for example, elderly patient with autonomic, not only autonomic problem, but now they people have limited reserve for everything. Okay, so maybe that change will be abrupt in that cases, diabetic patient, hypertensive patient. Okay, any patient with heart failure. So these patients will be at risk. So you just have to take care when you produce that position. You have to anticipate and react accordingly. Similarly, any position in which, with reference to respiratory system, the main effect will be in the form of airway pressures. Okay, airway pressures will be changed, and it will be resulting in decrease in tidal volume usually. So if it is increasing in the tidal volume, maybe it does not have that much effect. But any change in airway pressure and decrease in tidal volume, resulting in like decrease in minute ventilation, then hypoxia can occur. And then like there may be changes in end tidal CO. That is the basic concept. Yes, there will be some extra points which will be written, but the basic thing will be like that. Again, whenever a lot of effects will be there with reference to even CNS will be related to CO2. So whenever there is decrease in CO2, sorry, the increase in CO2 and a decrease in saturation, this will have effect on the pressures like intracranial pressure. Okay. So you need to be taking care about it. Intracranial pressure, maybe intraocular pressure. So things like that. Similarly, if you wrap the patient too tight, uh, you put prone position, okay, and now the abdomen is compressed. Abdomen is compressed in a way that now there is not only decrease in venous return, there is decrease in cardiac output. Now there is also the airway pressures are increased and there is problems in the ventilation. So you have to anticipate accordingly. So this will be the change you should be. That's why whenever we make a position, we keep make sure the prone position, we make sure that the abdomen is free. So abdomen should be free. Okay. And as I mentioned about the joints and pressure points, the same rule will be applied. With reference to I will just add on one thing that, for example, if there is not only there is the pressure, actually when we make prone position, eyeball is actually hanging. So it itself has effect with reference to the blood supply. Okay. So and if a patient has any risk of ischemic optic neuropathy, already patient has retinopathy, and you are having hypotensive anesthesia, and you are giving, for example, tranexamic acid, this will be a combination of things which we do in spine surgery. Okay. Like I'm sorry, spine surgery, hypotensive anesthesia. Okay. Then pressure or hanging. There is already retinopathy. So this combination will be, and then you are giving tranexamic acid. So tranexamic acid itself can cause microemboli. Okay, so this thing, not don't forget about it. Usually it is safe, it is being used frequently. That's why it is better to use tranexamic acid in an infusion. Okay, and any patient at risk, you should be taking care. Even you are giving tranexamic acid, nor frequently the gynae people love it, and as soon as yes, thoracic surgery as well. So gynae people are very fond of saying, please give 1 gram. So it is better to give it slowly. It is better to give in infusion. Okay. Usually around 10 milligram per kg. Usually it is the dose. You can give in bolus, but I will suggest you to give it slowly because you never know. Uh, Especially if you are dealing a obstetric patient, there is already hypercoagulable state. So this problem can be augmented. Okay. So actually, I have just given you a chunk, the main thing. Rest of the things, of course, is written in every book. But the I just wanted to give you a concept that whatever surgery you are doing, you should be you should be thinking in that way that these are the things which should be taken care of. Okay. So now we will just try to have few look on some of the surgeries, like some of the positions. What is the effect? Okay. So, as I use this word of ventilation and increase in airway. So actually, FRCA is decreased. FRC is decreased. So that will again, if you have the patient was in sitting position, there was no problem. Now you make the patient in supine position. Okay. So maybe that patient is not tolerating even supine position, and that patient might need to have head up normally. Okay, head up normally, and patient had like especially if the surgery is being done in regional anesthesia and patient is breathing spontaneously. Okay, so just give me a second, please. Okay. So I'm sorry. So actually, like you should be just knowing about it, because it will not be occurring in every patient, but ultimately, if there is any mismatch, there will be VQ mismatch. Okay. Like so, VQ mismatch you can tackle with giving some PEEP. Okay. So supine position, what extra points they have written? Neuropathies, pressure points. Actually, if you, I hope you understand that now, of course, you will find in every position specific points like they have you written here. Pressure point, what is there? Occiput, sacrum, and heels. Even heels, okay? Because heel will remain like that for many hours. So that will be then. Then what happens? Compression, excessive stretch, or ischemia. Again, you see the common things. Ulnar nerve, because ulnar nerve is in any position, ulnar nerve can be damaged easily because it's just near the pressure the bone. So it is something very vulnerable. Okay. I will just try to see anything extra. Lithotomy position again. You see, placing the legs in lithotomy position decreases the blood flow in the leg veins and redistribute this blood centrally, increases venous resistance to heart, therefore cardiac output. As I told, in susceptible patients, this increase in central flow can lead to pulmonary edema, as I told. Okay, so the same things we discussed. Any stretch in the Okay, lateral position, because there will be specifically we do it with reference to thoracic surgery, and there is whole of the concept which is hanging behind the one lung ventilation. So that will be something extra other than normal patient. If any surgery is done in lateral position without one lung ventilation or without whatever is going on in thoracic surgery, maybe the effect will not be that much pronounced, or any patient which does not have any respiratory problem, maybe this will not be very much evident, but this will be evident in any patient who have some limitation. Okay. Prone position we discuss. In here I will just tell you a few points that with reference to prone position, that prone position is used a lot in even in ICU for like any patient who is having ARDS and like not responding to the conventional therapies. Actually, remember one thing, this is intermittent prone position. Okay, because in prone position the alveoli which are not getting the oxygenation and perfusion will get perfused, and when you just like you are cooking food in one direction in the other direction on the pan, so it's actually almost like that. So like whatever alveoli are not perfused and ventilated in one position will be ventilated preferably when you turn the patient in prone position. So that's the concept. So that's why this is what you have to do. Okay. As I mentioned, this is the something again they have written here. Head and neck should be maintained in neutral position throughout. Okay. An excessive excessive positioning, excessive range of movement you should be avoiding. Beach chair. Yes, actually, I missed this thing, this point specifically with reference to beach chair position or any position in which the surgery is being performed above the level of heart, there is chances of air embolism. Okay. And of course, if you are making head side too much up, there is another thing which you should be doing, that perfusion pressure will be decreased. Cerebral perfusion pressure will be decreased a little bit. So if you are having an arterial line, you should zero it at the level of external auditory meatus rather than at the level of heart. I repeat, for example, you have a shoulder surgery and they are having surgery in this sitting position, and now you have arterial line. So you don't zero it at the level of heart. Zero it is it make the transducer a little high up, and zero it at the level of this one, external auditory meatus, because it will indirectly give you a better idea about the cerebral perfusion pressure rather than if you zero it at the level of heart. So this is something very, very important. You should be knowing about it. Okay. I think that's the same thing they have written here. Mean artery should be maintained more than 70. That's what, or you, if you have arterial line, you can manage accordingly, as I told you. Otherwise, You should not have too much hypotension. Okay. And again, you will have some patients at risk. The patients at risk, you should be more careful. Okay. Another point, it's just slipped out of my mind. Inna lillahi wa inna ilaihi raji'un. Let me think what I was about to tell you. Uh, uh, Oof, you see, just I forgot what I was telling. Trendelenburg and reverse Trendelenburg. Again, the same thing. Yes, I recall the point which I was telling you. We all the time we are doing this Trendelenburg position, especially when they are doing lithotomy position. And even today I was doing a case and the surgeon was asking for a done position. So on a lighter note, I said the patient, you can ask me to bring to take the patient to the ground floor. Okay, even I can go beyond the level of earth. But in that case, I will suggest you, I will try to explain, but usually it's not written in the book. It is something practical. Okay. Like, for example, this is the foot side and this is the head side. Okay. Like you are doing Trendelenburg head down position. Okay. Now the head is here, foot is here. What will happen? There will be increase in blood flow to the brain. And actually, if you just keep it for many hours, there will be increased chances of delirium. Okay. So actually, again, I tell you, maybe it is written in some book. I did not find this thing written in the book, but I have just devised or thought from my brain, and I used to do it. That what I do, that I just used to make this position like this, and then place a pillow here. Okay, pillow here under the head, just to lift the head, so that I am counteracting a little bit. Okay, not too much, but at least it will reverse. Like if the head, I'm very bad in drawing. If the head was supposed to be like this, if I apology, just a second. Like if the head was like this, in this, I'm just trying to make it like this. Okay. If I put a pillow, so the head will be elevated a little bit. So it will become like this. So even if the position is like this, maybe there will be some decrease in the engorgement of the veins, which would have occurred if I just did not do this. I hope you understand. Okay. So whenever you are doing a Trendelenburg position, try to put something under the head so that you counteract a little bit with reference to the increase in cerebral blood flow. Okay. So this will be just a help for you. Reverse Trendelenburg, hypotension. Okay. So actually, sometimes you mean you will flex the head. Yes. Yes. Okay. Flex the, not really head or neck, whatever. I hope you understand. So like you will do it just to avoid too much increase in the blood flow to the heart, to the head, to the brain. Okay. So that will be like advantage, or you will try to avoid. There are few positions we this not this is not only the one factor said. It is like, you can say that if, for example, it will remain like this for a long time, you have 4 hour surgery. Colorectal people do like that. Okay, they make the head side too much down, and you keep it for many hours, and have nothing uh, uh, went wrong, but still this will be a risk factor in that patient, that this patient will be at more risk of developing delirium. Okay. So you can avoid it by just raising the head side a little bit up. So this may be a little avoided, but remember one thing: if there is too much short neck and actually you obstruct the veins, then maybe the effect will not be coming. So maybe you can put something under the shoulders, and try to have a deal with the surgeon where he optimally needs it. Because whenever you are doing Trendelenburg position, airway pressure also increase, because all the abdominal viscera is coming upstairs, okay, towards the thorax. So airway pressures are increased, FRC is decreased. So there the patient might need more pressures to ventilate. So maybe this effect is not too much creating trouble for you in a normal patient, but the same if thing will be creating a lot of problems to you if you have a very obese patient. or you have a patient with any baseline COPD or anything. Okay. So this thing you should be knowing. Another just a small point about ramp.
Excuse me, sir.
Yes, yes.
Sir, would hyperventilating the patient also help, as decrease in carbon dioxide would cause cerebral vasoconstriction? Would that also help, or
Actually,
that
CO2,
not?
if you are washing, actually, you never want hypocarbia. You want a balance. Okay.
Right, sir.
Because
Right.
this is actually not related to CO2. This is related to direct pressure. You try to stand on your head. Okay.
Okay,
It
sir.
is
I
just
understand, sir. I understand, sir.
it is just like if you all of you want to understand what I'm trying to tell you, just try to hang your head down from the bed for a few minutes, and then you will understand what's happening to your brain. Okay. So if it is for
Okay, sir.
few minutes or few seconds, it is fine. But if you are doing it for a long time, that itself it's a problem. So that's it. So RAM
Sir,
position.
I also had a question.
Yes, yes, please.
Uh, Sir, regarding Trendelenburg position, the MCQ came in this year's theory exam,
Okay.
uh, in which they had asked which would be more significant during Trendelenburg position, the migration of the ETT due to the shift of the mediastinum superiorly, or
Okay.
the decrease in FRC due to the shift of the abdominal viscera to cephalad.
Like what exactly word they had asked?
Said I don't remember the exact MCQ
Yeah,
vignette and
because
the
you know
choices, but they
exact
were
stem.
comparing.
I tell you something. Migration of endotracheal tube
Sir,
can be managed, but FRC cannot be managed. Okay, so I would go
sir,
for FRC. Okay.
sir. So another
Or
question regarding the beach chair position.
mhm.
Sir, there's a concept called the basal gyrus reflex during the shoulder arthroscopic surgery while the patient is in the beach chair position. So, what is the cause of this basal gyrus reflex? Is it the beach chair position itself or the surgical stimulus?
Basal gyrus reflex in which surgery?
So, shoulder arthroscopic surgery in the beach
Shoulder
chair position.
arthroscopic surgery, I don't think so. I think it is because of the decrease in blood volume. Where when they are doing the this I have never heard about this thing. This is something new for me. So I will need to check
Sir,
it
sir,
out. Okay, because
sir.
what
So,
is
it is
basal
often asked
gyrus
in the
reflex?
MCQs. Sir,
Because basal
sir, sir.
gyrus reflex is like you can say that there is a hypotension and bradycardia resulting from like excessive vagal response. Am I right? So actually, actually, how it is related with the beach chair position? How it is? I have no idea.
Um, okay, sir.
Even
Thank you, sir.
shoulder surgery, I don't think so. They are doing anything with reference to vagal. So I'm afraid I don't have any answer for this question.
Sir, I believe there is also a mild relation with the mechanoreceptors of the heart that play a role in it. Also, I've also not fully understood the exact concept of it, but I read it from a book somewhere that they
Because you know,
can
basal
also.
gyrus reflex can occur even, can you believe this, with low dose of atropine. You have heard about it.
Yes,
Okay,
sir.
if you are so actually, this is not a very understood reflex. Okay, so this is just I will give you this explanation. Okay. So I
Thank you.
hope like I have given you a concept. Yes, I was telling you about ramp position. So I will you can say I will do a tabligh for ramp position. It is written only for obese or pregnant patient. Okay, but I will suggest you that make not as exactly, because in ramp position I will show you, just give me a second. I will show you because exactly ramp position is ramp position. Okay. So exactly in ramp position, you have to bring like this. Okay. So if you even don't do, even if you are not able to get things like that, because that will be required in obese patient. But at least if you just make a habit of raising the head side a little bit up, raising the head side a little bit up in a slanting way, you can say a sort of reverse Trendelenburg position. It is, there are so many advantages for it. Okay, there are so many advantages for it. FRC will be increased, airway pressures will be decreased. You will have very like you will feel very comfortable ventilation. You will, and then another thing, because the regurg, whenever regurg occurs, actually it's a passive phenomena in that way, because now the door has opened and the things will come out. There is nothing like vomiting reflex. It is just coming, the regurg occurs passively. Okay, so if you make head side a little bit up, you make a slanting position, it's actually a sort of prevention against regurgitation, because now the gastric content will have to go uphill against the gravity. So it needs more generation of more passive pressure to pull to push the food or whatever material upstairs. Yes, if it occurs, then you have to immediately reverse, because if the things are coming and entering in the wrong door, now it will slip down, trickle down. So that time you need to reverse that position. But otherwise, the advantage is to the ventilation will be easy. You are preventing from aspiration. And then another advantage is that the angle for intubation, that is oral angle and pharyngeal angle and laryngeal angle, you have to make it in a line straight, so that you are getting a funnel sort of thing. So when you are making a ramp position, actually your intubation also becomes very easy. So try to practice it. I actually a few years ago I had first experience of doing morbidly obese patient for this obesity surgery, lap sleeve gastrectomy. And actually at that time I started this thing. Before that I had never practiced this thing. So I myself started it and I found it wonderful. And now actually there is no patient which I intubate without making head side up. It makes my life much easier, because you have to take care of your back. Your back is only once, it is only for you, and nobody can give you his back. So to try to save your back, make the patient it should be at level of your belly, head. Because another advantage will be that you can use your belly to fix the head of the patient. So actually it has so many advantages. And try, if it is possible, try to keep the patient near to edge of the bed rather than sliding down. Okay, because if you make the patient straight, in majority of patients they will feel uncomfortable when you are anesthetizing them. But if you make head side a little up, any patient, even if the patient does not have any cardiovascular or respiratory problem, even then he will feel comfortable while breathing. So you can ask the patient to have deep breathing. Okay, deep breathing. Even I will tell you something, that even if you don't put the mask on the patient, even you just ask the patient to breathe deeply within the air, what will happen? You are only it is only giving you 21% oxygen. But what will happen, that if the patient breathe deeply, actually the alveoli will get open. So in coming few seconds, when you are actually anesthetizing the patient, it will help you. So I repeat, make a sort of head up or ramp position. Ask the patient to breathe deeply before inducing, and then you can put the face mask also. That will do the pre-oxygenation. That will do the finish the atelectasis, which is there in a number of patients to varying degree. Okay, to smokers, to elderly patient, to pediatric patient. Like there are so many patients which will be in that category. Okay. So thank you very much, all of you. It was like you can say again a journal discussion just to clear the concepts. And yes, anesthesia. This is, yes, my name. If Dr. Sad, you can give me if you found the link from somewhere, you can just message me. You can take my number and you can contact me anytime. Okay. So this is my WhatsApp number. I have, this is, just a second. It came as a direct message. Just a second. I will put it for everyone. So this is my WhatsApp number. I think I put it on the Facebook as well. So maybe you are following from the Facebook. Yes, yes, yes. So I suggest you take my number and just drop a message on WhatsApp, because not every day I send the link on the Facebook. I don't get the time because I have to share the link. I have around more than 4,000 people on board. Um, so thanks a lot, all of you, for joining. And any question you want to ask, even you can ask later on. I will suggest you to have a look on the previous discussions. Okay. Thanks for this interesting and useful article. Actually, all these articles are there. If some people who are new to me or who doesn't have this link or who don't look at it, I will suggest you there will be one link like this, and it has all the year wise. Okay. I share this every now and then. BG Education, Anesthesia Tutorial of the Week, Updates in Anesthesia, and this is another paid articles. This in this folder you will find year wise. Okay, so there is one link like this, and the other link is with like this one. I will show you with this name, Zishan's Anesthesia Data. So here I have arranged a number of topics, articles, the same articles topic wise, but unfortunately, since last 1 or 2 years, and I'm unable to update this folder. And if you want to have some extra new articles, I will suggest you to have a look on the year wise article folder. Here I have a lot of books arranged, like you will find review books for clinical sciences, basic sciences, ICU books, MCQs, OSCE books, textbooks, short answer questions books. Okay, like in MCQs folder you open, and I have dissected them in basic sciences, best choice, clinical sciences. This is all for everyone. This is for everyone. Okay. So anyone can use this and share it to others. So thank you very much. And this is the YouTube, the channel. I tell to everyone, I have no financial interest, and I'm not doing it for any financial interest. Okay. So like I have discussed almost all of anesthesia before in one way or other. Okay. You will find some related to religious activity, but just the other things, if you just want to have it, is I will suggest you to have this playlist, and you will find all the playlists. Okay, the people who are only understanding English, there is a folder with English discussion. So all the discussions which are being done in English, because initially when I started, I had few discussions which were done in my native language. So later on I just converted it to English, and now exclusively everything is in English. Okay. So then I came late. Anyways, you can search it, no problem. And all of you are welcome. I have put my number as well. So anyone who got the Zoom meeting link through Facebook, you can just drop a message on WhatsApp, because unfortunately I'm not very active in Facebook as much as in on WhatsApp. So thank you very much. And any question, you are welcome to ask anytime. This remember one thing, I love anesthesia more than I used to love yesterday. So I will suggest you, this anesthesia is a wonderful specialty, not because I am an anesthetist or you are an anesthetist. There is no other specialty which has so much diverse knowledge. And like if for example, if you want to become an anesthetist who give propofol and give saxamethonium and put the tube and sit down and sleep, it's very easy. Even before it was done before, by technicians. but if you just try to have something new, opioid-free anesthesia, low flow anesthesia, try to try different things, uh, then you will realize that anesthesia is something. Every day you have different challenge. Every day you have a different patient, and you should change your plan according to different patient. Dr. Saima, actually, sometimes I just have, because I'm trying to have a basic anesthesia care. Okay. So maybe I was just thinking maybe we will discuss post-op care. Okay. PACU. PACU. I was just thinking because we have started from then we can go for like we will go in details of different topic. Actually, I have discussed majority of topics. You can find the previous recordings, but because I don't make it as a like a formal discussion, so you will find something missing in some of the discussions. And anything you don't understand or any one of you does not understand, you can just drop a message to me that in this discussion, this thing I did not understand. So I will be happy to answer you. Okay. So thank you very much and bye bye.